Hello everyone. Today we are going to discuss a case of 26-year-old woman who rushed to the emergency department with sudden onset abdominal pain. So the lab report shows that the patient is suffering with anemia, and also the marrow is showing responding for the anemia. So having reticulocytosis, a high number of reticulocyte count has been noted, and white cell count has been depleted, and the platelet number is depleted. So you could make out that the patient has a kind of a pancytopenia picture. So this is what we are inferring with this case. So the patient is having pancytopenia, and also the flow cytometry studies has been done with the peripheral blood patient's peripheral blood cells. Like here it showed that the patient has deficiency of CD55 and 59 proteins. So also the CT of the patient's abdomen shows hepatic vein thrombosis, right? So what is the most likely cause of this patient's anemia? Their main concern is about the patient's anemia, reason for the patient's anemia, why the patient is having severe anemia manifestations. So right, so possibly here we are having a patient who is suffering with hemolysis. Looks like the patient is suffering with hemolysis, right? So this triad of this presentation, like the triad of hemolytic anemia and triad of pancytopenia, and this patient is having severe hepatic vein thrombosis suggestive of hypercoagulability. So whenever you have this triad of manifestations, you need to think about a condition called PNH. So the paroxysmal nocturnal hemoglobinuria, right? So usually the patients with PNH will have this kind of presentations, especially typically they do have CD55 and 59 mutations will be typical. So we'll just look at the options for patients anemia and we'll see which is the right option here. And we'll start with the choice E. So the choice E, the splenic sequestration can be seen in any anemia, like where you have the splenic sequestration is a most common complications seen with your sickle cell patients. So this can be seen with sickle cell patients, not likely with your PNH, the paroxysmal nocturnal hemoglobinuria. And again, the mutations in beta globin chain, this can be seen with your the condition called beta thalassemia. So beta thal conditions, you do have this kind of mutation in beta globin chain will be seen, and intracellular dehydration, so which is typically seen with the conditions called the hereditary spherocytosis. Also it can be seen with sickle cell diseases, sickle cell anemia, right? So sickle cell anemia, you have this intracellular dehydration will be seen. And factor 5 mutation, where patient will have too much of coagulation will be there, but the problem is with the patients will not have the hemolytic anemia or pancytopenia. So here no pancytopenia and hemolytic anemia, right? So here our patient had suddenly developed these symptoms. So when the symptoms can develop, any precipitating event in PNH, it can be an inflammatory events or it can be an infectious events, can trigger this condition called PNH. So what is the problem with PNH? So PNH is a condition where you have the patients will have an acquired mutation in PIGA gene. So acquired mutation in PIGA gene, So this PIGA gene mutation, like whenever the patient is having PIGA gene mutation, so this causes absence of a substance called the GPI. So the GPA are nothing but the glycophosphatidylcholine inositol anchor protein. So this glycophosphatidylcholine anchor protein is seen on surface of red cells, and this is responsible for binding the cluster differentiation components CD55 and CD59, right? So CD55, which is nothing but your the decay accelerating factor, right? And CD59, which is nothing but your MAC inhibitory protein. So basically these CD55 and 59 are like these are the complement inhibitor proteins. So whenever the patient is having absence of GPA, so whenever the patient is having loss of GPA, this protein cannot bind on the GPA surface. So the red cells can be the target for your complement substitution. So likely choice which is responsible for patient's sudden anemia is complement activation, right? So that's about the case of a PNH, which came to us with a severe abdominal pain, sudden onset abdominal pain, and lab reports revealed pancytopenia and flow cytometry. Again, it is classically seen with any cases of PNH will have this CD55 and 59 deficiency will be there, and the CT scan of abdomen shows hepatic vein thrombosis, so which is indicative of hypercoagulability. So it can be a component of a Budd-Chiari syndrome, right? So the take-home message is like whenever you see a patient with sudden onset anemia, hemolytic anemia, pancytopenia, and hypercoagulability, think that you are dealing with a case of a PNH, paroxysmal nocturnal hemoglobinuria, right? So the term, the paroxysmal or nocturnal, is a kind of a misnomer here. So the nocturnal is the hemolysis happens throughout the day, right? Remember the fact the hemolysis is happening throughout the day in the patient whenever it gets triggered, whenever the event is triggered, or whenever there is an acute episode. But uh, hemo hemolysis happens throughout the day, but in urine, usually in the night time, the urines become concentrated, so where you can make out this hemoglobin in the urine. So that's the reason they say it's nocturnal hemoglobinuria. Otherwise there is no specific reason to call that, right? So which is also important. So that's about the case of PNS. Thank you.